Oblique plane deformities, their analysis, planning, simulation, and surgery. This is a talk about the complex deformities that present to us, which we call as oblique. So the analysis of the deformity can be performed by the graphic method of Paley, the trigonometric method, and the Ilizarov method. For all practical purposes, the graphic method is a very useful method because not only does it help us to understand the deformity, not only does it help us to analyze the deformity, find the plane in which the deformity lies, find the magnitude of the deformity, but it also practically helps us to construct the Ilizarov apparatus and helps us to place the hinges so that accurate correction of that deformity will be possible. Now, the methods of correction of the oblique plane deformity can be either Ilizarov with the orthogonal method, which is very simple and a practical method which does not involve any calculations, or the more precise Ilizarov method with pre-construction using the graphic method of planning, and finally the much more high-tech, sophisticated and relatively simpler method for the surgeon, that is the use of the Taylor's spatial frame fixator. So the Ilizarov workflow consists of firstly analyzing the oblique plane deformity, taking those special oblique plane x-rays by positioning the patient accurately in that plane, then using the oblique plane x-rays to simulate the surgery using either software or using butter paper and tracing paper to perform the cuts of the bone to see how the deformity will nicely correct, and then performing the pre-construction of the Ilizarov apparatus the day before the surgery and checking it on the patient's limb to ensure that it is going to do the job perfectly. Let's start by taking a look at this young lady who had a valgus of 16 degrees and procurvatum of 48 degrees due to malunion of a supracondylar. The X-rays on the left show the 48-degree procurvatum and the 16-degree valgus. However, when we position the patient accurately in the plane of the deformity, what we find is the extreme X-ray on the right, which shows no deformity at all. And exactly at right angles to that plane, we can see the maximum deformity of 48. This can be explained in her right lower limb, in which we draw the graphic method by taking a cross section of the femur of the right lower limb. Since it's the right lower limb and we are presumably looking down at the foot from above, the medial aspect is towards our left, lateral is towards our right, anterior is above and posterior is below. The femur happens to lie not in the center of the limb but in the anterolateral quadrant, and hence the outline of the femur is drawn based on the measurements of the AP and lateral diameters of the femur. We keep a tracing of the ring of the Ilizarov system of either 150 or 60 or 180 degrees as per the size and shape of the limb. If it's a 48-degree valgus, 48-degree procurvatum, we draw a line 48 millimeters long with its apex towards the anterior, that is along the plus y axis. And since it's a 16-degree valgus deformity, we draw a line 16 millimeters. I'm sorry, the diagram says 48, but it should show 16 millimeters, which is apex medial for a valgus deformity. These two thick black lines then helped us to complete the rectangle. And in that rectangle, a diagonal dark black line is drawn. The red angle shows the inclination of the plane where the deformity lies. And the true magnitude of this deformity is also 48 degrees. If we extend the line above and below, in the concavity, which is at the posterolateral area, it gives us the position of the motor rod, which will be in the first posterolateral rod. Since we want to perform an opening wedge correction, we will draw a line perpendicular to this plane with the green colors, which shows us the position of the hinges that we need to place in order to get an opening wedge correction. In this case, it will be anterolateral third hole and the anteromedial eighth hole. By placing the hinges in this direction and by placing the rod in the concavity in the first posterolateral hole, and by distracting the motor rod in the concavity with an osteotomy that is performed at the apex of the deformity, we should get a full correction. So this is how we located the position of the hinge. We reconstructed the ring and placed it accurately on the patient's limb. The posterior motor distraction rod can be seen just disconnected before the corticotomy. This animation shows us the opening wedge rule, in which if the osteotomy is performed at the apex of the deformity and the hinge is placed at the convex cortex, we get a very accurate correction with no translations of the axis. So in the same manner, the osteotomy was performed in the posterior distraction rod helps us to get correction. As you can see in this young lady, she has been completely corrected and there is no secondary translation at all. Lengthening can also be performed. This young lady with cerebral palsy also had significant varus and procurvatum due to a fracture, varus of 48 degrees and procurvatum of 50. And we try to analyze this in this animation, in which we see that in the lateral view we've got a 15 to 16 degree procurvatum, and in the plane of the deformity we can see that the femur is not deformed at all. At right angles to that, then you see the maximum deformity, which is in this case is about 48 degrees. So as we move on to the next slide, we will see that we are able to use this understanding of the accurately place the lower limbs of the girl in the plane of the deformity to give us a true deformity of 48 degrees on this X-ray, and at right there you can see there is no deformity. Then we use the deformity plane X-ray to simulate the surgery to determine the shape of the osteotomy and where to place the hinges. So we have drawn the proximal and the distal axes. They intersect in the transverse bisector line, and by placing the hinge away from the convex cortex and perform the corticotomy on the apex of the deformity, we are able to achieve not only a correction but also lengthening by opening up a trapezoidal shaped wedge like so. Having done that, we now go on to create the apparatus and simulate, and this animation should help us to see how in the AP the apparatus looks and how in the lateral the plane of the deformity itself, and at right angles to this you can see the full extent of the deformity. Now you can see the hinges are placed away from the convex cortex, and upon an osteotomy at the apex and distraction of the motor rod, we see a full correction and regeneration of a trapezoidal shaped wedge of bone. Helps us to get a very good correction, and everything happened as to help give her a full correction of deformities in both the planes. So let's now come to rule 2, in which we often find ourselves in situations where we cannot perform the osteotomy exactly at the apex of the deformity. If we place the hinge at the cora or the axis of correction, but the osteotomy at a different level, we will still get a correction which is very accurate, but it is accompanied by a minor translation at the level of the osteotomy, and the overall axis lines up. Typically used in juxta-articular deformities and in the majority of cases in clinical practice. Let's take a look at this lady doctor who's 38 years of age with very severe varus and recurvatum procurvatum deformities. These are her x-rays. Let's take a look at the left lower limb, in which we find a very large varus deformity in the femur, some varus in the tibia, a procurvatum deformity in the femur, and a recurvatum deformity in the tibia. The trigonometric method helps us to locate the plane of the deformity as the inverse tan of tan lateral upon tan AP, and the magnitude of the deformity as inverse tan of the under root of tan square AP plus tan square lateral. Intimidating, the simple use of a calculator present in our mobile phones and laptops can help us to determine. So in the femur, we located the oblique plane deformity uh, in a plane of 30 degrees, because the AP virus was 40 degrees and the procurvatum was 24. The oblique plane was present at 30 degrees, and the magnitude of the deformity in the oblique plane was 40 degrees. Now let's go to the graphic method of planning for her left femur. You can see the outline of the femur is there in the anterolateral quadrant of the left side. You can see that the anterior is placed above, and since it's the left lower limb, medial is towards your right as you watch. So an apex lateral 40 millimeters outlines the 40-degree varus, and apex anterior 24 millimeters by the blue line shows the 24-degree procurvatum deformity. The rectangle is completed and a diagonal is drawn from the intersecting zero, the black line, The magnitude of that is 47 mm, so it's the true magnitude of the deformity, and it's at a 30-degree plane. When it's extended into the concavity, the white line shows us the motor rod position, and the purple line shows us how we can correct it using an opening wedge. The purple line, which is perpendicular to the white line, shows us where to place the hinges in order to get an accurate correction using an opening wedge method. If we wanted to use a neutral wedge correction, we would use the blue line, and if we wanted to perform shortening, we would use the red line. We took the oblique plane X-rays by positioning the patient accurately and found the maximum deformity on the X-ray on the left and no deformity at all at a plane right angle. We used the oblique plane X-ray to simulate the surgery on either a vector graphics program or an operative simulation software or on a butter paper. We decided where we wanted to perform the osteotomy in order to get a maximum stability and also take the minimum duration for healing of the osteotomy. Were we to perform an opening wedge correction in this patient, then we would get an opening wedge of a maximum extent of 4 to 5 centimeters in the concavity, which may have taken us as much as 5 to 7 months or even more for full consolidation. So we chose to perform an angulation translation osteotomy. The benefits is that there is immediate stability due to the invaginating edges of the osteotomy, as well as early healing of such. So now let's go on to the planning of the tibia. We had 18 degrees of varus in the tibia as well as 14 degrees of recurvatum. Using trigonometric methods, we found an oblique plane of 37 degrees and the magnitude in the oblique plane was 22 degrees of the deformity. Let's go to the graphic method of planning, or actually this animation shows us the how in the lateral X-ray we have the recurvatum, and in the AP X-ray we have the this is in the plane of the deformity at a plane of 37.5 degrees. No deformity is visible at all, and at right angles to this we can see the maximum extent of the deformity, which is varus and recurvatum. At this is in a plane of 307 degrees. So therefore we use the tibia graphic method planning. This is the left tibia. The medial aspect is towards our right. This is the outline of the tibia drawn, which is in the anteromedial quadrant. And we draw the deformities, which is the varus is shown as an apex lateral deformity of 18 degrees. It should be varus. It should read as varus. Sorry about that. And 14 degrees of recurvatum, which is drawn towards the negative y-axis. The rectangle is completed, and from the 0 position, a white line is drawn as a diagonal. It's at a plane of 40 degrees, and the magnitude of this, the length of this line is 22 mm, which is a 22-degree deformity. This line is extended into the concavity to give us the position of the motor rod, which is in the anteromedial quadrant, represented by the green line. By placing the distraction rod in this hole, we will be able to accurately correct the deformity. If we wanted to perform a closing wedge correction, we would use the purple line to outline the hinges. If we wanted to perform a neutral wedge correction or a rule 2, it would be in the center, and the blue line represents the opening wedge correction if you wanted to open a wedge and create a triangular wedge of bone. But in this lady, we want to use the white line, which denotes the neutral wedge, and hence this placement of locate the and decided where to perform the osteotomy in order to get a good lateral translation of the distal fragment and invagination of the fragments to give stability and healing. In this manner, the 3D simulation can be seen, in which we have recreated the apparatus. In the AP view, we can see the varus. On the lateral, we can see the recurvatum. And in the plane of the deformity, we see no deformity at all, wherein lies the rod of the concavity. At right angles to this, we can see the maximum deformity is visible and the hinges are placed at the level in order to get a opening wedge correction. So by distracting in the concavity, we are able to get full correction of the deformity. So this is to simulate and understand. And the exact plan was followed in order to get a good correction in the femur and the tibia using the Ilizarov external fixator. It's a hybrid fixator with both half pins and wires used. And you can see we have followed, and she has achieved a full correction of her deformity with the mechanical axis now passing through the center of the knee joint. Similar plan was followed on the right side to get a very accurate the deformities, as can be seen in this view with the pre and the removal of the fixator also enabled us to get a full range of knee motion with minimum scarring and no more procedure. We can also perform a fixator for oblique plane corrections, but let us now come to rule 2 deformity correction with this is a young lad who has got a varus deformity in the lower tibia along with some shortening. We need to perform a rule 2 correction here. The osteotomy happened to be a little further away from the apex of the deformity, and hence we need to perform much more translation of which we have achieved. A medial translation of the distal fragment helps us to line up both the proximal and the distal fragments after the lengthening. This bump is more visible on the x-rays but not clinically, and it will disappear within a year of the removal of the fixator. And it has helped him to achieve perfect access so that it will not trouble him in the oblique plane deformities with rotation can really present to us as very challenging cases. For your interest, I wish to present to you such an interesting case that came to us for oblique plane deformities as well as lengthening. This young lady has got varus recurvatum internal rotation deformities with a lot of shortening. Close to this is 24 degrees of varus, 20 degrees recurvatum, 60 degrees internal rotation, and 7 centimeters of shortening. So we use the Ilizarov fixator in the mode which allowed us to achieve length gradually with angular correction of the oblique plane. And then once the lengthening was achieved and the angular correction was completely done and the rings became parallel to each other, we were able to put in a derotation assembly between two parallel, as you can see in this picture, to achieve an outward rotation of the distal fragment to get this very accurate correction. Deformities in this lady with equal leg lengths, complete correction of the varus recurvatum and internal rotation deformities as well as shortening. Oblique plane deformities with also present in a much more complex manner with no need for lengthening, as in this lady who fell down from an airplane and her parachute refused to open and she developed these significant malunited femoral fractures. Of course, in the acute phase, she suffered badly and needed at least 40 units of blood transfusion, etc. She came to us 1 year after the injury with these malunions. She had not only varus of the femur, but a small amount of recurvatum as well as internal. So when we took the left femur to find the plane of the deformity and obtain the oblique plane x-rays, we found the maximum deformity like so in the left femur on the left and on the right femur. So what we have to do to correct an oblique plane deformity along with rotation is to use the inclined focal dome. Inclined focal dome, the hinges are not located one above the other as is seen in simple oblique plane deformities. And you can see over here that the upper hinge is placed much proximal to the ring and the lower hinge is placed at this level. So this is the inclined plane that you can see. The red line denotes the inclined plane. At the top or towards the left is the red line that denotes the inclined axis is inclined at 55 degrees to the horizontal, and you can see the distal hinge is very much the posterior hinge is very much distal and the anterior hinge is very much proximal, and the rod is on the medial side is the one in the concavity which helps us to correct the oblique plane as well as the rotation at the same time. The osteotomy is done in a inclined plane based on the wire, which you can see out shown by an arrow and a thin black line on this figure. And the same is the view from the top, which shows towards the left the anterior hinge, which is very proximal. The posterior hinge is below over here. This is the medial distraction rod, and the inclination of this wire shows the direction in which we are going. The same was done exactly as per plan on both the right and the left femora, and it shows us a very accurate correction of the femurs during the treatment in the AP view, showing perfect 87 degrees of mechanical lateral distal femur, like so, also visible in the result. As soon as the apparatus was removed, you can see the 87-degree from femoral center of the femoral head to the center of the knee joint, the angle made with respect to the femoral joint orientation lines in order to give this lady a perfect correction of her. And also on the lateral x-rays, the recurvatum has. Now, let us go on to lengthening malunions. As you know, limb lengthening can give rise to a lot of complications. The commonest complication is axial deviation, and malunions as a result of lengthening are not on. So, perform correction only, as in this young lad with chondrometaphyseal dysplasia who had a valgus deformity and procurvatum deformity as a result of lengthening. We need this set of X-rays shows the ankle malunion, which because of proximal overriding of the fibula, so we just brought his fibula in order to correct, relationship, and the valgus is corrected in the left ankle. However, we need to now look at the right tibia, which is in the procurvatum. The valgus is of 14 degrees and procurvatum is 26 degrees. In this case, also we can perform the planning. This is the right lower limb. We are looking down at the outline of the foot from above. Therefore, in the right side, medial is towards our left and lateral is towards our right. We have drawn 14 degrees of, so the concavity is towards the posterolateral aspect, and the rod which is placed on the third hinge in the posterolateral area, when distracted, will correct the deformity. Here we have chosen the white line perpendicular to the purple line which passes through the center of the tibia for correcting the angular translation deformity. And you can see over here how he has completely corrected his deformities. So if you want to perform correction of an oblique plane deformity and give shortening to the patient, this is also a circumstance that may sometimes be clinically seen. It is typically required in cerebral palsy for correction of uh, um, fixed flexion deformity of the knee, in which we have to also perform angular correction and correction of and perform shortening of the femur in order to mitigate the effects of spasticity of the hamstrings. Take a look at this lady. She happened to come to us from England. She had a lengthening procedure in the left femur and tibia, which ended up unfortunately as malunion of the femur and the tibia, as can be seen. This is not just an attitude of the limb deformity. It can be appreciated in the full length x-rays. There is valgus in the femur, valgus in the tibia, procurvatum in the femur, as well as procurvatum. Let us look at the tibia. These are her oblique plane x-rays, in which the x-ray on the right shows the true extent of the deformity, which is almost 20-21 degrees. The x-ray on the left is taken in the plane of the deformity and hence shows no deformity at all, as can be appreciated. It is a completely straight looking tibia. This is how we resolve the deformity, the oblique plane deformity. This is the left lower limb, so you can see the outline of the foot, and medial is towards our right, as can be seen here. Outline of the tibia is drawn and the anteromedial face of the tibia is facing the anterior and medial quadrants. A 10-degree procurvatum deformity is drawn as 10 millimeters in the plus y-axis, and a 12-degree valgus deformity is drawn as a 12 millimeter apex medial line. The rectangle is completed like so, and the diagonal line, which is this dense red line, shows us an almost 40-43 degree plane of the deformity itself, and 21 millimeters as the magnitude of the deformity. The concavity in this case is towards the posterolateral aspect, and when the line is extended posterolaterally, it shows us the so the purple line extended towards the concavity shows us the fifth rod in the posterolateral area, which will be used as a motor rod for correcting the deformity. Now, had we wanted to perform an opening wedge correction in her case, we would have used the light yellow line in the convex cortex of the tibia. But if we wanted to perform a closing wedge correction, we would have used the light blue line in the concavity to resect a bony wedge. But since we also want to perform shortening, we want to create a wedge, which is the dark purple colored line which shows the placement of the hinges. This will not only help us to achieve the deformity correction, but also help us to achieve lower limb. We use the shortening. This is rule 1. The cora is visible, and we have the cora and the transverse bisector line, which is the axis of correction of angulation, and we choose to perform the osteotomy as a closing wedge with the hinge on the concave cortex, and the bone is resected. Here in this case we would place the hinge away more towards the concavity to achieve as well. So how much shortening to achieve can be given by the formula for the chord length of a circle, and we resect a trapezoid in which we can accurately and see the shortening osteotomy is 2 pi r alpha divided by 360, which resolves to r alpha 57, and by doing that we could accurately not only straighten the limb in both the AP and the lateral planes, but achieve the desired as well, like so. To do so, this X-ray shows the preoperative plane of the deformity, the valgus, and postoperative correction with a completely. In a similar manner, the valgus and procfemur were resolved with the maximum oblique plane X-rays, which shows on the left side the severe deformity, on the right side no deformity at all. And using the graphic method for the left lower limb, the outline of the femur in the anterolateral quadrant, we have drawn the angles of 7 degrees of procurvatum, 14 degrees of valgus, and the rectangle is completed. The concavity is posterolateral, and the white line shows the placement of the hinges, which will help us to straighten as well as correct the deformity as well as achieve. And this is exactly what was done with the percutaneous osteotomy, the exact desired result that like so. So the Taylor spatial frame, which also helps us to correct deformities, it's much more simpler. This is a case of a malunion in a businessman with shortening, varus, procurvatum, shortening internal. So these are the parameters we feed into software, which helps us to perform the osteotomy at the right and slowly, gradually components of the deformity like so. He removes the fixed hands and has a completely accurate correction of deformity planes. Thank you very much for your attention. This was a diagram created by my 8-year-old daughter when she heard of the oblique plane deformity.